number, and sizes of lesions to finalize your strategy for the procedure. Then to ablation to determine flow within and near the lesion. This information could influence your plan for the sequence of ablation. To create an ablation 6 centimeters in diameter with the 5 centimeter device requires at least 6 overlapping ablations, as seen in this illustration. Depending on the shape of the lesion, usually some of the ablations can be done consecutively along the same track, requiring fewer puncture sites and needle placements. When doing multiple overlapping ablations, some physicians choose to ablate the area with the highest blood flow first, in order to make subsequent ablations easier. Others ablate the most distant and/or difficult area first. Note there can be some disruption of the visualization once an ablation is done, which could make subsequent placements more difficult to visualize. The most appropriate strategy for each patient is best determined by the physician. Patient preparation is relatively simple. The retina-dispersive electrodes are placed anteriorly on the patient's thighs. Prepare the patient using standard technique for electrosurgery. Skin-to-skin contact, such as between the legs or between the torso and arms of the patient, should be avoided. Otherwise, the patient is prepped and draped normally. Most physicians administer a local anesthetic along the track intended for the retina device. Also, for percutaneous cases, many physicians prefer to use conscious sedation, allowing the patient to be responsive but comfortable during the procedure. Transabdominal ultrasound is used to conduct a complete evaluation prior to any ablations. At this point, the sequence of ablations is finalized, and the lesions are measured. A biopsy is often performed on the first lesion to be ablated. Next, the device is placed under ultrasound guidance. If using the Starburst 3 centimeter device, the trocar should be placed approximately 1 centimeter from the center of the intended area of ablation. If using the Starburst XL 5 centimeter device, the trocar should be placed approximately 1.5 centimeters from the center of the intended area of ablation. Note that any structure not intended for ablation, for example the gallbladder or diaphragm, should be at least 1 centimeter from the intended ablation area. For this reason, a surgical approach may be best for surface lesions, where damage to adjacent viscera must be avoided. Then the electrode array is slowly deployed. Slight forward pressure is recommended for proper deployment. Ultrasound can be used to monitor deployment and detect any displacement of tissue. If doing a staged ablation with the Starburst XL, deploy completely to check positioning and then retract to the starting position. Once the device is placed and the electrode array is deployed and anchored within the tissue, the ablation can be started. To do this, turn on the RF power by depressing the RF on-off button. Observe as the temperatures increase. Once the target temperature is achieved, the generator will automatically adjust the power to maintain that temperature for the length of time you set. Refer to the instructions included with the generator for appropriate target temperatures and times for each ablation. The ablation occurs in stages over time. Initially, the heating occurs immediately adjacent to the electrodes and later is conducted to the surrounding tissue, creating a spherical ablation. Deployment is also staged to create the ablation more efficiently. During the ablation, the impedance is usually in the range of 35 to 100 ohms. If impedance rises above 100 ohms, refer to the troubleshooting guide provided with the generator. High impedance could be an indication of improper deployment, insufficient application of the dispersive electrodes, or charring on the electrode array. Often, outgassing at the ablation site can be seen on ultrasound, generally increasing in size as the ablation progresses. Or it could be left unchanged with the understanding that if adequate temperatures are not achieved, the area near the vessel may not be completely ablated. Often, if the vessel is smaller than 3 millimeters, it will eventually coagulate, at which point the temperature will rise rather quickly. Once an ablation or series of ablations is completed, the track along which the device travels can be ablated. Physicians generally choose to ablate the track in order to prevent potential seeding and to control any potential bleeding. If using the Starburst 3 centimeter device, you would watch the number 4 thermocouple during track ablation. If you experience difficulty in retraction,